Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm pleased today to be talking with Dr. Allen Dobson, a family physician in North Carolina, who has a very interesting career as a family physician and as a family physician leader. And today he's going to be talking about a residency program that he was involved in creating and led for a number of years. Allen, thank you very much for joining.
Thanks, Larry. It's good to catch up with you again after many years.
Yes, it has been quite a while. So tell me about, how did this residency program start? Why did it start?
I think probably the thing to understand is that when I left residency, I came to a small town, less than 2,000, to take over for a doc who'd been here forever, and with the vision of providing full scope family medicine, including hospital OB, home visits, everything that we get trained for in residency program. And I trained down in East Carolina, by the way. And what happened when we set up our practice, we became so busy and created several locations, and ended up taking care of a huge portion of the population, including other parts of the county that weren't even close to us. And then, if you recall, back in the 90s, there became kind of the feeding frenzy by hospitals to hire the docs. It was really hard to get partners. It was hard to get people who to actually come care for communities. And one of the things we learned from our decade of taking care of patients in the community is the family physician and primary care really is more than just seeing patients. It's about being a connector, a local leader, a problem solver for the community, because you are the healthcare system. And we knew very clearly, being in our community, that what a healthcare system for a small community is really a primary care office, a pharmacy, and an EMS station. That pretty much covers everything a small community needs for 85+% of their healthcare, if the primary care office is full service. What happened in the 90s, we couldn't get partners. Our community was really had more patients than we could take care of. And then suddenly, one of the largest medical groups in Concord, North Carolina, went bankrupt, and about 40,000 patients were suddenly without a doctor. We ended up having to take up that slack, but without the manpower to do it. And then we realized that if we really wanted to create a model where we had partners who shared our philosophy, learned how to practice family medicine as we were practicing it, we really ought to create our own residency program. All the rest of the programs were full. There weren't enough in the pipeline to meet our needs. And so we, started on this journey of saying, well, let's train our own. We had been doing medical school students for a long time, and that we had this vision that we needed to move away from the model practices, only train in the hospital, and do kind of a model practice that is mainly run by the residents in a way that's probably not as reminiscent of real practice situations as you might like, and move to an apprenticeship model where we would actually train people in the community where they would likely practice, with faculty who were full practicing physicians doing full scope family medicine, kind of as a junior partner, almost like in the old days that you learned how to make baskets from the master basket weaver, right? And we went down that road and created a fairly unique residency program with 4 different family medicine clinics, each with 2 residents in each class, and each clinic having at least 5 or 6 full-time faculty members practicing full scope family medicine. So it really turned out quite well.
My understanding is you had to have a sponsoring organization, which was usually a hospital, and the hospital collected all the direct medical education and indirect medical education funds from the government. And that sponsor thing was how did your business model work?
Well, we went to the hospital, and they, as I said, we had a primary care crisis. They needed to help solve it, and we basically made the proposition that we would do a partnership with them to create a new model of training family physicians who hopefully would stay in the community, that we would hire and replace the primary care that the hospital was missing, but that we wanted the model to be self-sustaining. And so we actually worked very hard to create a model where we said to the hospital, all the money that comes to the hospital for medical education, direct and indirects, will be put in, we will help manage that pot. You can fully allocate all your cost and we'll put all our cost in, but we're going to manage this and the docs will be on a performance basis, and the residency was on a performance basis, and show that we could actually make this a win-win for the hospital. The long and short of it, their upfront capital was paid back in the first 2 years. We ended up with a family medicine system that's was at least 40% of their entire referral base, covering the county. And we ended up having about 40 to 50 faculty members plus our 24 residents seeing patients in the hospital. So it turned out to be quite a successful model for the hospital and for us as a residency program.
So that's amazing in size. But one of the things that really strikes me about that is it's really bothered me to watch how family physicians have been driven out of taking care of their sick patients in the hospital. I mean, I understand what the pressures are that created that, but it sounds like you created a model where you didn't have to hand off. You could create an inpatient service that supported the whole, and you didn't have to hand people off, so you had much more continuity of care. Is that a fair assumption?
That was the basic design, because we had spent a decade taking care of our own patients in the hospital and doing OB. And our model was that all 4 of our clinics would admit their patient to our service, managed by the residents and the faculty. So our faculty would, take a turn in the hospital, spend the night in the hospital with the residents. And we, for medicine and most of their rotations, except for some of the specialty rotations, their core inpatient experience was actually on the family medicine service. And that persists today. Over 20 years later, the family medicine service at our hospital is the largest service in the hospital. And all our faculty and residents still care for their inpatient service.
That is fantastic. I wish all residents were trained in a model like that. By the way, you haven't mentioned the name of that residency program.
Sorry, it's called the Cabarrus Family Medicine Residency Program. And we were Cabarrus Family Medicine and still are. It's now part of Atrium Health out of Charlotte, but it has been a very successful program here in North Carolina.
So one of the successes that you mentioned with this model is the number of residents who stayed on in the community to practice. Could you speak to that?
Well, yeah, I mean, one of the hallmarks of what we were doing, we were trying to fill our own practices, so to make sure we had faculty, and so we were able to hire our residents after graduation, have them stay on, but the hospital wanted us to open other clinics in a successive ring of practices around the community, which we were able to do, and to hire our graduates for that. One of the things we did do early on was that, our mission was to train family physicians for small town practice for rural practice to be able to, practice in the style that we were practicing. And so we selected residents who wanted that track. They wanted to go back home, or they were from North Carolina, from a small town, or, they had connections that that gave us some confidence that they were going to go back and fulfill kind of their, our mission of having them go take care of folks in the community, and model for them the importance of leadership and living in the community where you practice, being part of the community, things that myself and Charlie Rhodes, one of my, my first, partner from residency program, and many of our folks who are part of the program have done, is that you're living in a community, you're taking care of the community, you're a leader in the community. You're just not a shift worker. Doesn't mean you can't have work-life balance. It just means that you do owe it to the community to provide leadership, whatever that might be. So we've been fairly successful, and I don't remember right off the top of my head the statistics, but we're one of the top programs for putting residents into small town and rural areas in the state.
That is fantastic. I congratulate you. One of the things I'm curious about is, for many family medicine residency programs that are fully within the confines of their sponsoring organization, a hospital or the healthcare system, there is, let's just say, there's lack of power to make decisions about what is in the best interest of the residents' training. It sounds like you've worked out a different kind of power relationship with the hospital that gave you more degrees of freedom. Could you comment on that?
Yeah, well, I think you're right. I think we don't take some of the power that we have. And I will say that, I used to say this to our fellow residency directors around the country: there's no better trained physician leader than a family medicine residency director. They deal with students and residents and personnel issues and complexities of finance and logistics and working, with administrations. And in some sense, when I ended up with another part of my career going into the state government and running Medicaid, I also told people my best training for that was being a residency director. So back to your original question, so I kind of got to sidestep that. One reason it worked was that we set a different covenant with our hospital. It was a business covenant, right? That you got to understand what the hospital needs out of an education program. We're passionate about education and the things we're doing, but that may not be what the hospital drives the hospital. We understood that their success was capturing patients, shoring up their physician referral patterns, because otherwise they'd be traveling to the big city or other people would come in. That we needed to be a business person first, so that the residence program wasn't costing them money. It could stand on its own and was accountable. But we were a huge help in recruiting specialists, because guess what? If we capture patients, and I think when I left, we actually had 100,000 active patients through the Family Medicine Center, right? Well, that's a pretty easy thing to calculate. How many cardiologists, orthopedists do you need to keep those patients home and be served in your hospital? So we were a huge, it wasn't that we made them so much money, but we were able to keep patients home and create them an economic model that they could grow the hospital based on supporting specialists.
That's very interesting that you mentioned that, and I absolutely agree with you. So back in the 80s, late 80s, I was at Penn State Hershey, and we took a look at the what we called then the downstream revenue associated with our family practice center. And we were able to document it, and we set up a meeting with a number of the chair of medicine, the chair of surgery, I think the chief financial officer for the hospital at the time, and presented that data, and they totally dismissed it. They said, look, you may think that they're coming to you, but they're really coming to you so they can get to us.
Right.
It's us that brings them. You know, it's our we're top flight doctors, and that's what people are after. But it sounds like in your setting, you were able to use that kind of data, and you had
Well, the advantage we
more
had,
leverage.
yeah, the advantage we had is that they weren't there before. We weren't.
There you go. Yeah.
Right. I mean, and the same thing with the hospital. It was that we were helping them solve a problem they needed to solve. And that's always the case. And I don't want to pretend that everything was rosy. I mean, and, there weren't, the same kind of dynamics over time, because that is true, but that is part of physician leadership, is learning how to navigate with your colleagues. And, we had to swallow our pride a lot, and we were like Mikey. We would do anything that was needed to be done. We would cover the nursery. We did OB for the health department for years. We even gave up the delivery money for a while so we could fund school nurses. You do what you have to do to make yourself indispensable. And in reality, the work of all the great faculty and having that vision of something different that allowed us to recruit some of the best docs I've ever worked with, who were really energized. They didn't have to make the choice between academics and actual, hands-on family medicine. That they could find that right blend. And so I think that's still present today.
So one of the hallmarks that I've learned over the years of a family physician leader is his or her ability to respond to the service opportunities that are available within their marketplace, within their community. And it sounds like that's what you did. You responded to the service opportunities. You had generalist physicians, both residents and faculty, as a pool of people to shape that response. And it sounds like that worked very well for you.
I think so. And I think I still think that we rely too much on not training in the real world. I mean, I think the notion that we have now of the teaching health centers is a positive one, where you're allowing residents to train in real life situations where we need more of that, away from the especially rich ivory towers. Because if you're in Mount Pleasant, you have to think twice about having someone drive 30 minutes to get care. If you're in Alaska, it's a big decision because you got to put them on a plane. So I think that we need to not give up our comprehensiveness, for sure, in our training, and we need more models where we can show, the satisfaction of practicing that way. Larry, I've kind of done all types of stuff. I still live in the same town I came to in 1983. I can't live it. It's, that's another story, but it's a small town, and it's home. And even though I don't actively practice day to day, having just, retired, it is that connection to the community that is a big part of what makes us family physicians anyway.
Great. Well, Allen, I want to thank you for talking with me today. Dr. Allen Dobson, a family physician, founder of the Cabarrus Family Medicine Residency Program, a very interesting and unique model with some great outcomes. Thank you very much.
Thanks, Larry. Good to talk to you.